Yes. Good morning, everyone. The hearing will be starting very shortly. Today's hearing consists of Level 2 evidence. Under Level 2, the public gallery will be closed. Only a few accredited journalists will be allowed into the hearing room whilst evidence is being given at Level 2. Everyone else is able to view the proceedings in the annex, subject to a 10-minute delay. No one, whether a member of a legal team, an accredited journalist, or members of the inquiry staff or contractors, are permitted to bring a personal electronic device into the hearing room. This includes mobile phones, even if switched off. So please take this opportunity to have one last check to make sure you have no electronic device, including smartwatches, in your possession. The inquiry security team will be able to arrange safe storage of any such devices during Level 2 hearings. Please ask at the security desk. And please remember to allow sufficient time to arrange safe storage for your devices before the afternoon proceedings start. Thank you.
Yes, Ms. Bolton.
Sir, you have in front of you Dr. Stephen Cockcroft.
Yes,
Please, may he be sworn.
certainly.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give should be the truth, the whole truth, and nothing but the truth.
Thank you, Doctor. Would you like to sit down? Because
Yeah,
that's
please.
how the microphones are arranged.
Thank you.
Questions will come from over there, but they're recording rather than amplifying mainly, so
Okay.
make us hear.
Hello, my name is Emily Pottle, and I ask questions on behalf of the inquiry. Could you give us your full name, please?
Yeah, Dr. Stephen Cockcroft.
Dr. Cockcroft, you prepared two statements, and they are inquiry reference 004608. If that could be brought up, please.
Yep.
You should see that on the screen in front of you. And if we just turn to the last page, page 7. Do you recognize that as a statement that you gave to the police?
That is correct, yes, I did.
And the second statement is inquiry reference 005937. And if we could turn to the last page, do you recognize that as the second statement that you gave this year on the 18th of July?
That is correct, yes.
And are both of those statements true to the best of your knowledge?
Yes,
and
they are.
belief? Sir, may those be adduced into evidence?
Yes.
Dr. Cockcroft, in March of 2018, you were working as an ICU consultant and anaesthetic consultant at Salisbury Hospital. Is that right?
That is correct. I was on call for the weekend.
Okay. So you were on call when Sergei Skripal and Yulia Skripal arrived at the hospital, and you managed their care in the intensive care unit until Dr. Haslam took over in the afternoon of Monday, the 5th of March.
It was the first 24 hours of the hospital admission, yes.
Yes, because they arrived on the Sunday,
Yes.
didn't they? So you looked after them for those first 24 hours. You had no involvement in the treatment of Dawn Sturgess, is that
None
right?
at all. None at all.
And you had only limited involvement with Charlie Rowley, that being part of his post-hospital discharge
That is
monitoring.
correct. I conducted some blood tests on him.
Okay. I'm first going to ask you, Doctor, about Yulia and Sergei's presentation in the emergency room. And I'm going to begin by taking you to the statement of Dr. Paul Russell, which is inquiry reference 5990, paragraphs 5 to 9.
Yes.
Do you see that in front of you?
I have. I've seen this document before, yes.
You have, okay. Dr. Russell says that he was on duty as a locum trust doctor in the emergency department. From about 2:30, he was attending to patients admitted to the resuscitation area. And at 16:40, the department was alerted of an inbound female with a Glasgow coma scale of 3. We heard from Dr. Haslam yesterday
Yes.
that means it's the lowest level,
Absolutely.
unresponsive, yes, profoundly unconscious patient. Dr. Russell continues that the duty anaesthetist, accompanied by his supervising consultant, attended the emergency department prior to the patient's arrival. Was that you, the supervising consultant?
I think it probably was. I'd briefly gone home thinking that was hopefully the end of my work for the day, or the weekend even. And no sooner had I got through the front door, my home phone rang, and Dr. Nash, my registrar, alerted me that they were expecting 2 recreational drug overdose patients and that they were both unwell. Could I come back and give them a hand?
I see.
So I probably turned him in the department just as he was turning up, just as the patients were turning up.
I see. So you had returned because you had been alerted by your junior colleague,
Yes.
Dr. Nash, who features, I think, in the medical records that we'll come to. And the information you had been given by him was that these were drug overdose patients.
Yes, to put that in some sort of context, in the months preceding this, Salisbury had an unusually large number of recreational drug overdose patients presenting. Salisbury is a sleepy little city and we don't get much of that sort of thing. But we'd had a whole run of them, and at any one time there was one of these patients either on the intensive care unit or nearly coming to the intensive care unit. It had become a local problem.
I see.
Yeah, and the area where these 2 patients were found was actually the area notorious for this recreational drug activity.
I see. Dr. Russell continues that at about 5 o'clock, a late middle-aged male patient was brought into the department, closely followed by a younger woman. That's Sergei and Yulia Skripal. As we were not expecting the male patient, I asked one of the attending paramedics who he was and was told that he had been found with the woman. Both appeared to be unconscious. The woman required assisted ventilation. As the resuscitation department only had 3 bays and 2 were already occupied, the 3rd bay had to be split. The female patient was attended to by the duty anaesthetist, along with one of the emergency medicine consultants, and the male patient was attended by the consultant anaesthetist and the other emergency medicine consultant. And so you attended Sergei, is that right?
That's correct. I'd taken a brief history from my registrar and the other emergency department consultant about Yulia. She had apparently been in cardiac arrest at the scene and was having advanced life support carried out. She now had a cardiac output, and so she was stable at that point.
I see.
Whereas Sergei was going to need certain interventions to make him safe. So I set about carrying those out.
So she was stable at that stage, and so you decided to focus your efforts on Sergei because he needed more interventions at
Well,
that stage.
yeah, she was stable in that the emergency interventions had been commenced, and Sergei hadn't had any of those emergency interventions carried out. So he was at risk of sudden deterioration.
I see. And then just to complete Dr. Russell's statement for this stage, he says, given the clinical information provided by the paramedics and the circumstances and location where the pair were found, the working diagnosis was a likely drug incident, suspicious of fentanyl or fentanyl analog or a similar acting drug. And then he explains that in retrospect, he thinks some features were organophosphate poisoning. Before we move on to your thoughts about diagnosis, which we will come to, I'd just also like to ask you about something said by paramedic Louise Cox. There's no need to bring up the statement, but I'll just give the reference for the transcript and serve for your note. It is Louise Cox's statement, inquiry reference 004931, and it is page 5, paragraph 2. She explains that she was a paramedic treating Sturgess Skripal. She explains that when she arrived at the hospital, she gave a full handover. She says, as I left A&E, I heard the doctor, she doesn't specify who, make a call to TalkSpace. This unit assists to find a cause of the presentation. Do you remember anyone making a call to TalkSpace, or did you do that?
I may well have done that. I can't recall doing it.
Okay.
I'm sorry, say that again, please.
Sorry, I may well have done that. I
Right.
can't recall doing it.
Okay.
But it's certainly something I would have thought about doing. Yeah.
Okay. And is she right when she says that this unit assists to find a cause of the presentation? So do they assist with helping clinicians work out what might be causing the symptoms, where you suspect that there is a sort of toxic...
If there are more use where perhaps you're dealing with a commercial compound, such as, let's say, an insecticide or weed killer,
Okay.
where it's not obvious what the active ingredients are. They have an encyclopedia of just about every product you could buy commercially. They're not so much useful for labelling something given a list of circumstances. So if somebody's swallowed something, let's say a cleaning fluid, if we want to know what the active ingredients are, then certainly we would consult that.
I see. And so I appreciate you can't remember if you did that, but what would be, in this situation with Sergei and Yulia Skripal, what would be the advantage of contacting TalkSpace?
The more I think about it, I'm just wondering whether it was me, because it wouldn't have made sense for me to want to do it at that stage. I was probably too busy treating Sergei.
I see.
I know I certainly accessed TalkSpace much later on in the day when they were stable. Well, when they were more stable on the ICU.
I see.
So maybe it wasn't me.
Thank you.
Sorry.
No, of course. Can I take you now to the contemporaneous medical records? So if we start with Yulia's records, the reference is inquiry reference 005544, page 3. And so you'll recall we considered this record in some detail with
Yes.
Dr. Haslam yesterday. But just very briefly now, we can say that this is a record from the emergency department. It's not filled in by you. No. But it records that on arrival, and this is Yulia's record, that a 33-year-old female was found behind Tesco, unresponsive, and profusely vomiting with an older male in a similar condition. They conducted the ABCDE assessment when she arrived at the hospital. So her airway, they noted that the eye gel was in place and that she was tolerating it well. She was breathing assisted by a bag valve mask, so she had assisted breathing at that stage. Her heart rate was 42, which is on the low side. She was unresponsive. So Glasgow Coma Scale 3. If we turn over the page, we can see that she was cold to the touch. She had no needle marks or open wounds. She was fecally incontinent. There was intravenous, intraosseous access. Naloxone was given to her. There was no effect. Atropine was given to her to increase her heart rate, and it did increase to 140 beats per minute. She was intubated, and the hypothesis at that stage was overdose, CT scan to rule out a bleed. Toxicology consulted max dose to be given of naloxone is 2 grams. Does that accord, that sort of record of the assessment, does that accord with what you observed in the emergency room with Yulia? I appreciate you weren't specifically focused on her, but does that roughly accord with your memory?
It does. I was keeping an eye on what was going on. I was in the adjacent bay, and Dr. Nath and myself were discussing the presentation of both patients. I mean, I was really concerned for Yulia Skripal's welfare. I honestly thought this lady was likely to have already suffered catastrophic brain damage, and I wanted to expedite getting her up to the ICU and trying to preserve what neurological function she may have had left.
I see. I'm going to move on now to, still with Yulia, but looking at her care in the intensive care unit. If we move to page 14 of the record. This is a record completed by your registrar, I believe, Dr. Evans.
Dr. Nath, it would have been.
Ah, because I can just see at the top there. Do you see on the
Oh,
upper
Evans,
left
yeah.
hand? It
No,
says
that
Evans.
is probably, there's a bizarre system. He would have been the duty medical physician on call. So when patients are admitted to Salisbury Hospital, they're assigned a named consultant, be it a surgeon or a physician or a paediatrician. So Dr. Evans would have been the medical physician on call, who at this stage wouldn't have even been aware that these patients were in hospital under his name.
I see, okay.
So that's who Dr. Evans is.
So he's a kind of figurehead.
Figurehead,
yes.
absolutely.
Okay.
Yes.
As the person who's the admission has happened under, if I can
Yes.
put it that way. All right. But he wasn't actually delivering care for Yulia at that
He
stage.
wouldn't have got involved until the next day.
I see. So the record says it's the 4th of March. We're still on that first day,
Yep.
7 o'clock in the evening. It describes ITU admission, and that first page is roughly a summary of what we already saw in the clinical notes from the emergency department. So it explains that she was brought in by ambulance and that she was unconscious. It records that her temperature was 30 degrees. That's quite low, isn't it?
It had been a very cold day. There'd been a lot of snow in the Salisbury area, and if she'd been lying unconscious on the floor for any length of time, her body temperature would have started to fall. But yes, that is hypothermia.
I see. And there is recorded there that she had, she's unconscious, it says, not maintaining her airway. She's unresponsive. It says no drug paraphernalia at the scene. She was given a jaw thrust. She was found to be bradycardic. No obvious external injuries. And an IGEL 3 for the airway by the paramedics that we know about. It also records, in sort of the second paragraph, it says, I think that's bronchial secretions. Is that right, do you think? Thank you.
Oral secretions.
Oral secretions, I see.
I mean, that would have been, she presumably been vomiting at the scene, and that's
Yes.
would be my assumption that that's what that is referring to.
Yes, we in fact, we've heard evidence from Dr. Helen Ord, who was present at the scene as a passerby, and she described a lot of saliva in Yulia's mouth as well.
Yep.
It also records that her pupils were 2 millimeters and not reacting. And then if we turn now to page 16 of that document. We can see now the consultant named is you, Dr. Cockcroft, is that right?
Yes.
And it's the same date, but later on in the evening at 23:50.
Yes.
Is that right? And you record events noted from 7. So does that mean that you had seen the record?
This
Just looked
record
at.
actually, it's slightly confusing. The day registrar on with me on that Sunday was a Dr. Nath.
Yes.
This was the night registrar, Dr. Nash.
Oh.
They changed over at 2000 hours. So
I see.
that's Dr. Nash having had a ward round with me and going through what we were dealing with and sort of summarising where we were.
I see. Dr. Nash.
Yes.
I see. Okay. So he filled this in, but you are now the named consultant
Yes.
because you're responsible for Julia's care at this
Yes.
stage. I see. Dr. Nash notes the second line, I think it's unclear history. Is that right?
Correct, yes.
Okay. And he also notes potential poisoning, criminal proceedings, police involved and present at the ICU. We'll return in a moment to the police involvement. But can you tell us at this stage, you were considering a poisoning as a cause for Julia's symptoms, is that right?
For both the patients, yes.
I see. And can you just tell us, why did you think it might be a poisoning as opposed to an opioid overdose?
There was a gentleman in his 60s with, I presume his daughter, because they had the same surname. It's not a normal presentation for recreational drug overdoses. It was too extreme, and certainly you couldn't tell much from examining Yulia because by this stage she was unconscious and sedated and on a ventilator. But at this stage, Sergei was behaving in an extremely odd manner, a manner which I'd never seen before. And I'd seen something similar a few years earlier. But around the same time, one of the police constables came up to me and said, I think you should Google Sergei Skripal, doctor. You're not going to believe what I've just found out.
Okay. If I can just pause you there, I'm going to take you to the statement of the police officer,
okay.
so we will cover that
Okay.
in some detail. But just for now, if I can ask, now that we look at Sergei's contemporaneous medical record, that is inquiry reference 006126, page 3. Again, we've covered this with Dr. Haslam, so I'm going to
Yes.
take it quite briefly. But the record shows that he's brought in by ambulance to the emergency department, found unresponsive by passers-by. He's similarly profoundly unconscious with a Glasgow coma scale of 3. Naloxone, it says, was given to him. Just to pause there briefly, we know now that he was actually given atropine by the paramedics in error.
Yeah, that's correct, yes.
At that stage, yeah. So he arrived in the emergency department. The airway, breathing, circulation assessment was done. He had a nasopharyngeal airway, and he had trismus, which is that clenching of the jaw. Is that right? He was, unlike Yulia, he was breathing on his own at that stage. He had reduced air entry on the left side. And can you tell us, looking at the assessment for his breathing, it says respiratory rate 14. Is that low or normal?
It's a normal resting respiratory rate. It's adequate. It's not particularly low.
I see. Okay. And Dr. Haslam explained to us yesterday that the rest of that line explains that he was receiving oxygen at that stage, and that his saturation was 100, as you would expect.
That's correct.
Yeah. And then if we turn to the next page, circulation, we can see his heart rate was 88. Oh, sorry, the pages are in the wrong order, so it's actually page 2, I think. Thank you. So his heart rate was 88. He was profoundly unconscious. His pupils were pinpoint. Naloxone was given, and he had no reaction. And for him, the diagnosis was overdose or aspiration. The aspiration is, I think, the paramedics had witnessed that when he vomited at one stage, he aspirated the contents as he was breathing.
When one's unconscious, you can't protect your airway. So if you vomit, a lot of the contents of your stomach can find their way into your trachea and soil the lungs, and that's what we call aspiration. It's potentially life-threatening. Aspiration pneumonitis can be lethal.
So it can be lethal on its own, and so that was a possibility as a sort of diagnosis for why he was so unwell.
It's possible, but obviously something had rendered him unable to protect his airway. So I would have viewed this more as a secondary complication to whatever the primary problem was.
I see. If we turn then to page 5 of this document, we'll see the record of his care once he comes up to the ITU. So you are the named consultant at that stage.
Yep.
Did you write this?
I did, yes. This
you
is
did.
my brief notes. I should point out that not only were we actively resuscitating the Skripals, we had something like 8 other patients on the ICU, some of whom were dangerously ill. So we were multitasking. My notes perhaps aren't as contemporaneous as I would like with hindsight.
You were busy with
Yes.
the patients, I see. But you found a moment to record
Yep.
at nearly 9 o'clock that evening.
That is correct, yes.
Yeah. And so you record that Sergei was admitted to the ICU following emergency admission. The patient presented with also with his daughter. They were unresponsive outside the Maltings car park. You explained that naloxone was given, that he was unresponsive to pain, that he was intubated. We can see that.
Yeah, I conducted that myself.
Pardon me?
I conducted that intubation myself.
I see. You conducted the intubation. And the last entry, can you help us with that? It says not...
Okay, so yes, whenever you come across somebody who is unconscious in an acute situation, you always want to rule out an intracranial event, be it a bleed on the brain or some sort of trauma. I mean, it was just possible that perhaps these individuals had been assaulted. So I took him once and intubated him for a cranial CT scan. There wasn't a consultant radiologist available to report the scan, but I'm capable of analysing them myself. And
If I can just pause you there, just so
Sorry.
that we can take a note. So there wasn't a cranial radiologist there.
No, but having looked at the stock, that's what I mean by not reported. It hadn't been formally
see.
reported by a radiologist.
I see.
But I'd given my opinion, and I could find no evidence of trauma, no space-occupying lesion. So by that I mean either a tumour or a blood clot. There's some enlargement of the lateral ventricles. Now that is something that happens with age and isn't necessarily of pathological significance in people the wrong side of 60.
I see.
And there was some evidence of cortical atrophy, so the surface of the brain was looking slightly worn, should we say.
But that's as you would expect for someone of his age, is
Yes,
that right?
yeah,
I see.
absolutely compatible with that.
I see. Can we turn to the next page, please? So we see here you've set out the ventilator settings, is that right?
That is correct.
For Sergei. And CVS, is that central venous?
Cardiovascular system.
Ah, I see.
So by unsupported, I mean we weren't giving him any drugs to support his blood pressure at this stage. He was maintaining an adequate blood pressure and adequate tissue perfusion.
I see. I see. And we can see at the very bottom of the page that there is a toxicology screen, and it says, note, Wiltshire Police intend maybe we can expedite toxicology. Is that
I've
right?
written, it's my writing, note Wiltshire Police interest, maybe we can expedite toxicology.
I see, I see. Well, we will now turn to the police involvement. If we can look at the statement of Detective Inspector Ben Mant, the inquiry reference is INQ 005669. And if we look at page 8 of that statement, So this is Detective Inspector Ben Mant's statement. He explains in the second paragraph there that he and Detective Sergeant Bailey arrived at Salisbury District Hospital. So this is 1 o'clock in the morning, so on the 5th of March, so very shortly after the patients were admitted. They attend the Radnor ward, and you weren't there, but the nurse in charge indicated that you were happy to receive a phone call and that you would expect to be called. And so the nurse in charge called your number and you spoke with Detective Inspector Mant.
From memory, I think I was on the paediatric ward at the time.
I see.
He phoned me on my mobile phone.
Anyway, wherever you were, they found you, did they? On the phone?
Yeah, on my mobile phone, yes.
Yep.
Yes.
I remember the conversation.
Yes. So Detective Inspector Mant says that he asked you what you knew about the patients and that you explained that you had Googled Sergei and you were aware of the spy link. We agreed that it was very out of the ordinary for Salisbury. And the police officer was relieved that you already knew about this link because it made life easier for him in terms of disclosing or sharing information. We then went on to talk about what may have caused their illness. And you explained that the tests for alcohol, paracetamol, and acetylsalicylic acid, which is aspirin, had been completed on site. You had also asked for urine toxicology scan for opiates and cocaine, and that it was not a quick process, and that you asked whether the police could do anything more quickly, and the officer said that he would be asking for pre-transfusion blood samples anyway, and that they could fast-track the examination of the blood and urine for other substances, and that you were grateful for this. And in fact, we heard from Dr. Haslam yesterday that those results, in fact, came in on the Tuesday, so a bit earlier.
That is correct, yes.
Than the results than the test that went to Birmingham. You had agreed that it was unlikely to be radiation poisoning or ricin, of which you had some previous experience, as the symptoms for those poisons have a slow onset. And the police officer notes that that was consistent with the advice given to his superior by CBR and experts. And that you and D.I. Mant discussed whether this could be a suicide attempt or a homicide, suicide attempt. And you stated that you felt that it was most likely that some form of poison, in fact, had been ingested. And you thought that the cause may have been ingested due to the speed of onset of the symptoms. And you explained that they were both currently sedated in order that they could receive supportive therapy. So from this conversation recorded with Detective Inspector Mant, we can see that your thinking around that time was not that it was a drugs overdose, but that it was some kind of poisoning.
Correct,
Is that
yes.
right? Yes, okay. Did you consider at that stage, because Sergei and Yulia had meiosis and vomiting, secretions, incontinence, bradycardia, did you consider that nerve agent poisoning was a possibility at that stage?
I did, but of course that's a pretty wild thing to suddenly think of in Salisbury in the early hours of Monday morning.
Yes.
They were quite different in their presentation. They had different. They presented differently. They weren't showing the same symptoms. We had Sergei Skripal, a gentleman who, not in the first flush of use, who seemed to be tolerating reasonably well, other than the fact he was unconscious, whatever poison had been he'd been subjected to. He had his 33-year-old, presumably much medically fitter daughter, was seriously, dangerously unwell, and that's the one thing that confused me. I couldn't, unless somehow she'd received a bigger dose of the agent, but without knowing how it had been administered, I couldn't really. There was something very, very wrong going on. And
So the fact that they presented differently, are you saying made it a bit more difficult to arrive at a diagnosis?
it did, because it was almost looking at two separate patients. I was convinced they'd been poisoned, but they were ill the wrong way round, if you see what I mean.
Yes.
I had seen something similar many years earlier, and yeah,
So you have some previous experience of poisoning by a highly potent synthetic opiate, and applying your previous knowledge, did you think this might be a similar kind of poisoning?
I did.
Is that right, Dr. Cockcroft? What you've been asked is whether you had previous experience of a
Yes,
highly toxic synthetic opiate.
that is correct. I had.
And you
yes.
had you?
Yes, I had back in 1993.
Right.
And subsequent to that, I maintained an unhealthy interest, I suppose, in the use of these agents. I know the Israeli government, it's on record, tried to assassinate somebody in Jordan using a synthetic opiate. And I know the Russian government had deployed such agents in Chechnya and in a Moscow theatre siege situation. So I knew these agents were out there.
Yesterday we heard...
Just a minute. I'm trying to see, Dr. Cockcroft, how much of this is clinical and how much of it is other research or interest that you'd
I suppose
accumulated.
Both, I suppose. Having it was a distinct possibility that there was a synthetic, highly potent synthetic opiate involved. I should perhaps mention that many years ago I'd done a pharmacology degree, so I had an interest in all matters pharmacological. So I maintained that interest through my professional career.
I see. Thank you.
And yesterday we heard from Dr. Haslam about your initial diagnosis, because you, of course, handed over to him. And his recollection was that you were considering poisoning by a strong-acting synthetic opiate, such as carfentanil.
Correct.
Is that right? Okay. I'm asking you this because there is, in the statement of Dr. Russell, which we looked at earlier, he records that in his conversation with you, you thought that it was fentanyl related. And I'm just going to pull it up now. It's inquiry reference 005990, paragraph 13. Thank you. I then went to the ICU to discuss the patient with the duty consultant, Dr. Stephen Cockcroft. I raised the possibility that the patients could have been poisoned with a nerve agent, but at that stage, he was convinced that the likely agent was a fentanyl-type agent. Now, before I ask you to comment on that.
When's he speaking of, Miss Pottle? Time? Date?
Yes, he's talking about during the day on the 5th of March.
Monday.
Yes, that's right.
Thank you.
Yes.
I do recall that conversation. It may be that Dr. Russell misheard what I said, carfentanil and fentanyl, unless you know an awful lot about these drugs. And as an anaesthetist, I know an awful lot about fentanyl. One might assume that they're very similar drugs, as they have very similar sounding names. Carfentanil has a potency hundreds of thousand times greater than fentanyl. Mm-hmm. Fentanyl in itself is an extremely potent opiate. We use it as an anaesthetic agent.
Yes.
I use it daily, and it's extremely dangerous in recreational hands. Carfentanil is off the scale.
Yes. Well, the way Dr. Haslam described it yesterday, he said that carfentanil is not a drug of abuse.
No.
So that would point to a poisoning.
Yes.
Whereas fentanyl is a drug of abuse, isn't it?
It is. Unfortunately, it's like to reducing death, fentanyl. It's a very dangerous drug to abuse.
Yes. But the difference for our purposes is that if we're talking about fentanyl, that could still be on the, if I can put it this way, the drugs overdose hypothesis, whereas carfentanil is not a drug of abuse. It is a poisoning, as opposed to an overdose, if I can put it that way.
It would definitely be an assassination attempt if one deployed carfentanil, yes. Yeah. It could have only one purpose, and that's to kill.
I'm now going to ask you about the sedation hold where Yulia regained consciousness.
Do you mind if I just go back to one tiny detail, Ms.
Yes, of
Potter,
course.
before you go on to the sedation hold? I may simply have misheard or misunderstood, Dr. Cockcroft. It's very likely. But I think at the beginning you told us in relation to Yulia that the report was that she'd been in cardiac arrest at the scene.
That was what I was told, that she'd stopped breathing, and that
That she may have stopped breathing. But I'd ask your help, Miss Potter. I've tried to check back. I don't recall, but I may have forgotten any reference to cardiac arrest from either Dr. Ord or Mr. Parsons, who were the principal people who attended Yulia at the scene. Have I got that wrong?
That's right, sir. There's
Right.
no evidence from them of a cardiac arrest. Yeah.
Right. And
I think it was probably just a miscommunication. I
Yes,
think
well, that's always possible,
in the
Dr.
heat of the moment in the emergency department, somebody told me that, you know, she'd had CPR, she'd had cardiopulmonary resuscitation, and I just took that as fact.
well,
and
that sort of thing.
treated her accordingly.
Please don't think it's a criticism. I just wanted to see whether there was a report which was different
Okay.
to what I'd understood elsewhere. All right. Thank you very much.
In your witness statement, you state that Dr. Haslam ordered the sedation hold.
Yes.
And in fact, Dr. Haslam's evidence was that he ordered the sedation hold and that it's a routine practice.
Is that right?
It is correct, yes. And somebody where we're concerned about neurological injury, we like at intervals to try and wake them up gently to see what their underlying neurological function's like.
Yeah.
He said that he ordered it and that he was still on the ward when she awoke from the sedation, but that he was in a meeting. And he said that it would be common practice for the treating clinician not to be present during the sedation hold, and that that nursing staff could be by the patient's bedside. Does that accord with your understanding?
I personally, if I ordered a sedation hold on a patient, certainly a young patient, and that was the first sedation hold, I personally wouldn't physically leave the ward, because some of these younger patients can wake very quickly and can do themselves harm. And we keep these patients asleep using infusions of drugs rather than boluses. So when the infusion pumps are turned off, consciousness can return in an unpredictable way. But the downside to that is if you then have to suddenly re-establish sedation, you turn these pumps back on and it can take sometimes 5-10 minutes to get the level of the drug back up to resedate the patient. And that is potentially quite risky, and certainly a younger patient who's combative can injure themselves.
Okay. So you're saying that wouldn't have been your practice,
No.
you would have been there.
I don't wish to be critical. The fact they called me in urgently was because they presumably couldn't find my colleague.
I see. If it was suggested to you that you had allowed Yulia's sedation to wear off and that you took the opportunity to ask her questions, what would be your response?
No, that wasn't the purpose of my intervention at all. I'd been treating another patient, and in fact, I think I was actually putting an invasive catheter, a central line into a patient. So I was gowned up and scrubbed up when the nurse looking after Yulia opened the door and sort of didn't scream exactly, but said, "Steve, come quick. Yulia's getting out of bed."
I see.
And I went in there, and yes, she was getting out of bed, and she was attached to a ventilator. I think at the time she was attached to a dialysis machine. She had several drips in her neck that were giving her vasoactive fluids. She was at risk of extubating herself, possibly aspirating.
And so you attended the bedside to help keep her safe?
Absolutely. I sort of grabbed hold of her hands because she was trying to clutch. I seem to remember at a dialysis catheter, and that's a big catheter in a large vein.
Yes.
She tore that out, she could have bled catastrophically.
I see.
And she was strong, so I grabbed her hands and started to talk to her as the nurses were hastily trying to put the infusion pumps back on. And it took about 5 minutes for her to go back properly to sleep.
I see.
And during that time, I was trying to, I'll be honest with you, I was actually gobsmacked. This was a girl I never thought I'd see move again. I never thought she'd be capable of having a conversation. I was quite convinced she suffered catastrophic brain damage. And I couldn't believe that she could be as neurologically intact as she obviously was. She was looking at me, she was nodding, she was crying. She looked absolutely terrified. And I was explaining to her where she was, explaining to her that this happens, often in, imagine a road traffic situation where you've got an entire family on ventilators on the intensive care unit, and the mum's waking up and wants to know where her husband is and where her children. You can't just not talk to them.
I see.
And you don't know how much of it they're going to take in, but even if they just take in a small scrap of what you're saying, it may offer some reassurance. And all I desperately really wanted was the sedation to go back on and the whole thing to stop.
Of course. Can I ask, at one stage you asked her about who had poisoned her?
If she had any knowledge, and I didn't really think I was going to get
Sorry, say that slowly. You asked if she had any...
I asked her if anybody had attacked them.
Wait a minute.
Or because I did say you've both been taken ill, your father's in the next door room,
Yeah.
we think you've both been poisoned. Did anybody attack you?
Right.
And by that stage, I think it's fair to say the sedation was beginning to take hold and she was beginning to slowly drift off to sleep.
Right.
So I didn't really put much store in asking that question. It was more just to reassure her, if she was capable of comprehending, that we were onto her case and her father's case and that we knew what we were doing.
I see.
Were you any more specific than did anyone attack you?
Did anyone attack you? I think did anybody spray something over you?
You asked if she'd been sprayed.
Yes, if she was
Your
aware.
word, not hers.
She couldn't speak. She still had
Right.
An endocrine tube.
Did you ask her anything else?
Not from my knowledge, no.
Following this
Very
incident, Dr. Christine Blanchard, who was the medical director at the time,
Yes.
she removed you from the ITU rota.
I'm afraid so, yes.
Is that right? Okay. And in her opinion, it hadn't been wise to speak to Julia about these matters. Do you agree in retrospect that it would have been better to leave those questions for those who were charged with investigating the matter?
I don't know the answer to that. I, at that stage, had been an intensive care consultant for 24 years. And I've seen good intensive care doctors in my training and during my time as a consultant, and I've seen bad intensive care doctors. I think the worst intensive care doctors are the doctors that ignore the patients. I've seen people conduct ward rounds and start undressing patients because they're sedated, yet they don't talk to them. I always talk to my patients, even when I think they can't hear me, explain what's happening. Some may think I'm slightly strange, I don't know. But it is recognised that you have to be open and cognizant that these patients may be confused, but they're certainly very frightened. 2/3 of our intensive care patients are emergency admissions. They've got there as a result of some sort of emergency. And, they all suffer some sort of post-traumatic stress. Anything you can do to reassure them, no matter how. Yeah. I genuinely was concerned that if she had had some knowledge that somebody had assaulted them, that might be something she'd be concerned about. Now, whether or not she was capable of remembering that, I just didn't know. But what I didn't want to do was then, in other episodes where our consciousness returns, to have some memory of that and not think at least we weren't thinking about it.
I see.
And that's where I was coming from. I have to say, I thought Dr. Blanchard's attitude was a little difficult. I was the consultant with 24 years intensive care experience. She trained in gastroenterology, and I don't think it ever worked on an intensive care unit.
I see. In your statement, you say that, as well as removing you from the ITU rota, that she warned you that you should not discuss any aspect of the poisonings with colleagues.
That is correct.
Or other individuals.
That is correct.
You were advised that any discussion would be treated as a serious misconduct.
That is correct.
Okay. If we can turn to your statement, inquiry reference 005937, paragraph 6. you say that this is your statement. So you say the irony is that I was the ICU consultant on duty on the 4th of March and was directly involved with the initial resuscitation of Sergei and Yulia Skripal from the moment that they were admitted to Salisbury District Hospital. And I provided ICU support for the following 24 hours. However, as a result of that meeting with Dr. Blanchard, I was forbidden to discuss any aspect of the presentation, recognition, or initial treatment of Yulia or Sergei Skripal. We would normally have monthly ICU morbidity and mortality meetings, but any discussion of the poisoning attempt was forbidden. I do feel this was a lost opportunity to discuss with colleagues what I observed in those first few hours and how I recognized that the Skripals had been poisoned. Dr. Haslam's evidence yesterday was that, as well as formal debriefs, which we'll come to, there was an informal sharing of knowledge among the 7 intensivists at Salisbury District Hospital. I think he described WhatsApp groups and so on. Do you feel, therefore, that you were not able to share your information with the other intensivists at the hospital in that informal way?
It was a very difficult time. Yes, I do feel I wasn't able to share it. Bearing in mind, my office was actually on the ICU. And that office, the duty ICU consultant would use it, but it was also my office on a daily basis. And we'd come in, and if they were having a conversation, they would stop talking about it in front of me. Mm-hmm. It was odd. It was very odd. I'm
going to ask you now about the more formal debriefing process. So you resigned, actually before that, I'm going to ask you a bit about training. You resigned in January of 2019 from your post. And your last working day was April 2019 at Salisbury District Hospital.
That is correct, yes.
Okay. So prior to your resignation, I'm going to ask you about whether you received training on the distinguishing between opioid and organophosphate poisoning. But before you answer, could we take up an extract from the expert report? It's INQ reference 005994, page 18, it's the last paragraph. Dr. Cockcroft, this is an extract from the expert report of Dr. Jasmeet Soar and Jerry Nolan, which I think you've seen.
That is correct, yes.
Yes. They include in their report a summary of Novichok toxicity, if I can put it that way. And they also describe here that several features of organophosphorus nerve agent poisoning overlap with those that occur with opioid overdose. For example, meiosis, respiratory depression, coma, and slow heart rate. But excessive secretions and sweating are not typical of opioid overdose. This has led to the suggestion that organophosphate poisoning should be termed the wet opioid toxidrome. Between the events in Salisbury that you were involved in and your last working day in April of 2019, did you receive any training on distinguishing those two causes?
No, I didn't.
No.
I had prior knowledge as part of my intensive care training. It was a subject that was touched upon because the most common reason one might see organophosphorus poisoning is as a result of some sort of agricultural mishap.
I see.
We don't use those agents in Europe, but in certainly the Indian subcontinent and the Far East, organophosphates are commonly used and commonly cause accidental toxicity to those handling them. So you had some training on that kind of poisoning. Oh yes.
Well before the events in Salisbury. I see. But I suppose what I'm asking you about is this overlap between the two and helping clinicians distinguish between opioid overdose on one hand, which I appreciate is very common, and organophosphate poisoning on the other, which is not very common. I'm wondering whether you had any training on distinguishing between those two.
Not at all. One thing I would say is that there's another symptom of opioid poisoning. Some of these more potent opioids cause extreme muscle rigidity. So the fentanyl compounds, the sufentanyls, the carfentanyls, part of their action is extreme rigidity, which both Yulia and Sturgess Inquiry exhibited. But then you get that with organophosphate poisoning as well. They exhibited that.
Okay, so there's another crossover you're saying. Yes.
And the other crossover, which I know now why, but one of the training, a lot of organophosphate poisoning is brought about by inhalation of the agents, and that causes much more respiratory symptoms. So the patients develop a severe asthmatic reaction, if you like, and they produce copious amounts of secretions from their lungs and effectively drown in their own secretions. That again is a textbook response to organophosphate poisoning, which wasn't exhibited in these two cases.
Yes, we didn't have those bronchial. We
No.
heard this from Dr. Haslam as well.
Is this idea of an overlap of symptoms new to you, or was it something that you knew perfectly well?
I certainly the symptoms overlap. Yes, I didn't. I'd never heard that term before, wet opioid. But yes. I mean, they're quite close.
I see. Yep.
Now I'm going to ask you about the formal debriefing process. You were invited to 3 debriefing meetings. You set that out in your statement. We don't need to pull it up right now, but the reference is 5937, paragraphs 8 to 10. The first of the formal debriefing meetings was organized by the Health Protection Agency.
That is correct.
Yes, which is a part of the Department of Health, and that was held at Portendown.
It's a separate office, DSTL. It's in Portendown, but that's entirely coincidental.
Yes, and that was in April of 2018. You say in your statement that you were prevented from speaking at that meeting by Christine Blanchard. Is that right?
There were only, from memory, she was present, Dr. Haslam was present, and one of the lead doctor for the emergency department was present, and myself. And when asked by the chair, could I describe what I'd witnessed, I was very rapidly interrupted and said, we don't need to hear this now. We need to discuss the public health implications of this.
I see. Dr. Blanchard, was she involved in your invitation to that meeting? Do you recall?
I'd already been approached. I can't remember by who, but it was a doctor from the Public Health Agency telling me that they were going to have this meeting, and I was sent an email, and he said he'd be in touch with the date and the time. And then I'd heard a rumour that it was happening quite soon, and I contacted him, and he advised me again by email that the invitation had gone to Dr. Blanchard to invite people from Salisbury Hospital to attend the meeting.
I see.
I didn't receive such an invitation, so he sent me one direct to me.
I see. And do you know why you didn't receive the invitation?
I don't know. I don't know.
Okay.
I suspect, yeah.
Okay. When the conversation was steered away from from clinical practice with the Skripals, were you told that patient confidentiality was a reason for not discussing their care?
I can't recall that. I mean, this was patient confidentiality. This was a meeting to which only certainly the members of the public were not present. There were physicians, there were scientists, there were other people from other government institutions, and I felt it absolutely vital that we share the knowledge. Some of the things that were being discussed were, I don't know how much more I can say without causing a problem. I met some very heavy-duty military people, should we say.
And it was important, you felt, to share the learning.
Absolutely.
I see. Because Dr. Haslam, evidence yesterday was that for quite a while, the Skripals were unable to give consent
Yes.
while they were being treated. And his evidence was that this prevented the sharing of details of the clinical care provided. Is that accord with your recollection or no?
It may well have been a view of some individuals, but I think there are patient confidentiality is absolutely paramount. But there are certain situations where the GMC, which is my governing body, would suggest that actually, if you don't share certain confidences, you can find yourself in an awful lot of trouble. For example, if you have a patient in the emergency department that's been stabbed or shot, it is not a defence to say that you're not going to share that information with the police because you are obliged to do it.
I see.
And even if the patient's telling you, no, I don't want you to tell the police, I'm sorry, I have to.
I see. The second meeting was at a lecture theatre in Salisbury, in the hospital itself.
That is correct.
On the 21st of June of 2018. Were you able to participate in that lecture?
That was unfortunate because actually on that occasion there were almost all the doctors in the emergency department there, certainly almost all my anaesthetic and intensive care colleagues, plus other specialties, a lot of intensive care nursing. This would have been an ideal opportunity to discuss how the Skripals presented and, share the secret, as it were. And I remember the meeting was chaired and I was called up with the nurse that was in charge of the ITU, and when I started to speak, I was told I wasn't required. That what the purpose of the meeting was to discuss aspects of the hospital's response to handling the Skripals. This was just before the Sturgess incident, and communication issues with the pathology department, that it was of no interest to know how the Skripals had presented.
I see. The final debrief was at DSTL Porton Down on the 12th of July.
Yes.
And I think in your statement you say on that occasion you were able to describe in detail your clinical observations.
I gave a half-hour presentation.
I see. Okay. The last matter I'd like to ask you about is about your frame of mind, if I can put it that way, following the attack. So following the attack, the authorities recognized the risk that Novichok may have been discarded, posing an ongoing risk to public safety. Were you warned at any stage of the risk that Novichok may have been discarded, meaning that there existed an ongoing risk of future contamination to members of the public prior to Dawn's poisoning?
No, I didn't.
Were you aware of the possibility or not?
I did wonder, but I thought, if these GRU agents and they're doing their job, then they shouldn't be.
Well, that's as it were. Yes, I see it. All right. Well, that was your reasoning.
Yes.
I think we've been told that the whole of Salisbury was aware that the police were searching all over the place. Were they?
I wasn't aware. Initially they were searching the venues that the Skripals had known to have visited just prior to the poisoning and after the poisoning, because they'd got around a little bit before they became unwell. So there was a pub that was stripped, there was a restaurant that was stripped,
Right.
There were park benches, there was a car removed, and then there was some contamination of the detective sergeant and his house in Alderholt, which is a few miles away from Salisbury. So there was all that going on, but I was not aware until after the Sturgess presentation that the police were combing the rest of Salisbury. After that, they were.
I see. Thank you.
That's my understanding.
Dr. Haslam has said in a public interview, we don't need to take it up, I'll read it out to you, his thoughts on the subject. He says, "On discharging our last patient, there was a real sense of relief or accomplishment. Things started to return to normal. All the fanfare of the press and everything had gone. In the back of our minds, there was a sense that the police hadn't found the Novichok And so there was a niggling feeling. Could it still be out there? Do we need to be worried? Did you share that kind of niggling doubt with Dr. Haslam? or
No, no, not at all. I didn't discuss any aspect of that with him. I wasn't aware of any conversations along those lines.
Okay. Thank you very much, Dr. Cockcroft. I don't have any further questions for you. Sir, it is a bit early for a break, but I imagine the family do have some
Well,
questions.
let me inquire how long you're likely to be. Mr. Mansfield, have you some questions, first of all?
I do. I would normally say, as yesterday, 10 minutes, but maybe a little bit more, given some of the observations.
Would it help you if I were to break now?
It would, yes, thank
In
you.
that case, I will. 20 past 11, please. Can you just keep your own counsel in the interim, please?
Yes, of course.
once you've moved it,
Yeah.
it will stay where you put it.
Great.
Until you press that little button. Don't press it.
Don't you press it?
Welcome back, ladies and gentlemen. We will be starting again shortly. This is just to remind anybody who may have accessed their electronic devices during the break to make sure you haven't brought it back in with you. Just check your pockets. Thank you.
Sir, if I may, I have one matter I'd like to clarify with the witness.
Yes.
Dr. Cockcroft, I said that I had no more questions for you, but I have just one.
Okay.
When I asked you earlier about the sedation hold ordered by Dr. Haslam, you said, I personally, if I had ordered a sedation hold on a patient, certainly a young patient, that was the first sedation hold, I personally wouldn't physically leave the ward because some of these younger patients can wake very quickly and do themselves harm. Dr. Haslam's evidence was that he hadn't left the ward, but that he was in a meeting, but still in the ward. Did you mean that you wouldn't leave the bedside?
I wouldn't go very far from the bedside. The fact that the nurses, and there would have been 2 nurses in Yulia's room at the time, didn't know where he was, meant that they couldn't find him. If he was in my office, then that was out of the main doors, down a corridor, round a corner. And if he was in a meeting, he may well have shut the door. He certainly wouldn't have been within earshot. So I don't mean to be critical of Dr. Haslam. I really don't. But I've been around the block a lot, and I've just seen so many sedation holds go horribly wrong.
And you would have stayed
Yes.
near the bedside or near the
Yes,
bedside?
and I would have probably made sure as well. I would have had some boluses of sedative drugs drawn up, because, as I say, when you've turned these infusion pumps off, it takes a little while, and all of a sudden then the sedation level drops, the patient's awake. You've not got very long to put them back to sleep, otherwise you engage in this rather unseemly fight. I'd have had anaesthetic agents drawn up ready to go to re-induce sedation within 10-15 seconds.
I see. Well, thank you very much
That's
for that.
my own personal
Yes.
thought. But
Thank you for clarifying that matter. I don't have any further questions.
Thank you very much, Mr. Mansfield.
Thank you. Good morning. My name is Michael Mansfield. I represent the family of Dawn Sturgess. And were you aware at the time of her death?
yes, I was. I mean, I was back. Well, I wasn't working on the intensive care unit at that stage, but I was aware she was in hospital. Yes, and it was being talked about. Yes, yes.
And would it be fair to say that the only difference between the meetings where you weren't allowed to say much about your experience and the one where you were, which was after her death, the only difference was, in fact, her death?
I'm not quite sure I understand your question. I didn't I went back to work on the. I'm trying to quite remember the date.
Yes.
My first duties back on the intensive care unit was the day after Sergei Skripal was eventually discharged, and I can't remember what that day was.
Yes, I can put that date to you if it helps.
Okay. I remember it was a weekend. I did a weekend's duty, and then about 2 weeks later, I did a week's duty, and then I don't think I worked on the intensive
They were
care unit.
discharged on the 16th of May.
Right.
Does that help at all?
If that's a Friday or a Thursday, then I would have been on call for that next weekend.
Yes.
But I didn't attend any meetings.
I mean, were you told before you went to the last of the meetings you've identified in your statement at Porton Down on the 12th of July? She died before that, Dawn Sturgess. Were you told why you were now going to be allowed to present?
No, I wasn't.
You weren't told?
I was invited directly by the staff
Yes.
at DSTL, and it was a much more formal situation where several of us, not just intensive care, there's one of my intensive care, Dr. Haslam was there, and there was a chemical pathologist, there was a neurologist, and we were all sort of discussing in a scientific manner what had gone on. It was
Yes, I want to develop that a little bit retrospectively at the earlier stage. Now, without obviously duplicating everything you said, that you indicated that what you had been prevented from doing was obviously describing your experiences and what you'd observed in the first few hours. You remember that's how you put
that's
it today.
correct, yes.
And how you recognised that that's the previous Salisbury incident, was a poisoning. That's how you put it today?
Yes, I'd agree with that.
Yes. Now, I want to deal with those two, so that if you had been able to, at either of the two previous meetings, first of all, without repeating your evidence today, could you, as it were, highlight what it was that you observed in the first few hours that you would have wanted the audience to understand?
Yes, there were certain things that, with hindsight, they then both went on to develop once the atropine had worn off. It was this inappropriate, profound sweating. Yulia exhibited from the outset, Sergei didn't. It was only 18 hours later, when the large dose of atropine had received ceased to work, that he started to sweat. And it was something I will never forget. The intense salivation, Yulia was exhibiting that quite early on. I think it stopped because she became quite dehydrated. I think it got to the point where she was unable to salivate. Sergei wasn't... Sergei wasn't able, again, didn't start to produce this intense salivation until about 18 hours after he'd admitted to the ICU. And with hindsight, that's something I just felt people needed to know. Something
People
I'll never
needed
forget.
to know. Now, before just moving on, is there any other feature that you would have wanted to put over in the earlier meetings?
I think also the fact that, again, over the years, when we have discussed organophosphate poisoning, it's always been drummed into us, these patients die a respiratory death. They drown in their own secretions. They develop an intense asthmatic type reaction. They get profound bronchoconstriction that doesn't respond to conventional asthma medication. That didn't happen in this case. And again, I felt that's something that I ought to share because it's not what the textbooks told us.
Yes. And, sorry, is there any other feature, or are those two you've just mentioned?
I think the only thing, I think with hindsight, I had it slightly easier because of the dramatic revelation as to who Sergei Skripal was and who
I
he'd
see.
been. I mean, that just set off a tremendous alarm bell.
Sorry, just say that again for me.
So in the emergency department, I was concerned that Sergei and Yulia had been poisoned, And then when I found out about Sergei's history, it just confirmed my worst fears.
So that wasn't a clinical assessment, it was...
Well, it was putting my
because
finding
of what
into
you'd learned
context.
about him.
Yes, and putting it into context.
I see. Well, right, and are you saying that you wanted to tell everybody else that?
Well, I think everybody knew that, but it was more what I'm trying to say is that I think I had it slightly easy because of the nature of the way he presented and who he was. There wouldn't have necessarily been a motive for, Charlie Rowley or Don Sturgess to...
I'm going to ask you, it's not a clinical question as such, but it may bear upon it. Do you think it would have helped had the authorities let the hospital know at a very early stage in the Salisbury Skripal incident that the authorities knew exactly who he was? Would that have helped you or hindered you?
I don't... It would have probably helped, but I mean, it's quite difficult to keep information like that confidential. If there had been some alert system, maybe that the police had,
right?
I'm sure they have individuals who do receive priority security. A lot of people in the Salisbury area are retired senior military officers. I imagine there is some sort of log as to where they live.
Well, please don't just guess, Mr. Colcroft, Dr. Colcroft. You're here to give evidence about the clinical aspects of the treatment of these people.
If the police had told us early on that who he was, that would have been helpful.
Right, thank you.
In my opinion.
Now, just going back to your observations earlier about what you'd observed in the first few hours was linked to this observation that this would, and how you recognise that it was poisoning. So are the two closely related in the sense that what you've just said about the main features was how you came to a view that it was poisoning?
Yes.
Or is there anything else?
No, that was it. That was it. There was something... This was not a recreational drugs overdose. That was quite apparent to me.
Yes, I understand. Now, just taking it back to the meetings where you didn't, or were forbidden for saying anything, the issue of confidentiality has raised its head, and I just want to deal with this with you, if you can, on a clinical basis. Where it is vital for other practitioners to know what you know, in case there's a repetition the next day or within the week or whatever, is this something which happens quite regularly, that practitioners will meet?
Yes.
And yeah, I'm quite finished, but that'll do. I think they meet and they discuss what their findings are.
We have regular morbidity or mortality meetings.
And it doesn't depend on any consent from a patient. You can do it anonymously. Is that right?
We do. The patients are presented by their age and their initials and whether they're male or female. But of course, some of us immediately recognise who those initials refer to. But we don't discuss who they are, but we discuss their presentation, lessons learned. You see, we get some very, very esoteric cases on intensive care. I can think of several that I wouldn't necessarily have picked up quickly that my colleagues did. And as a result of us discussing such cases, I'm better prepared to pick up such cases in the future. It's common to all medical environments. Mm-hmm. We discuss, we have multidisciplinary teams to discuss such patients.
Yes. Of those meetings, just one further question. Is it common to keep a record of what's been exchanged in the meetings?
Yes, somebody
and
takes the notes.
Who does that normally?
It would probably be one of the consultants who wasn't presenting that particular case. So it tended to follow that one of the intensive care consultants, his or her role would be to organise these monthly MDT meetings, and they'd set the agenda, they would get the notes out, and they would be probably the ones, unless they were presenting themselves, to take the minutes.
All right. Now, in relation to the two meetings where you didn't present what you wanted to present, and you've told us today, did anyone else in those meetings discuss or put forward the criteria that you have put forward to us today?
No, not that I can recall.
what I'm meaning is, did anyone else, was anybody else able to say, these are the early signs of poisoning, this is how you recognise it, this is how you distinguish, the overlap question, all that?
I can recall nobody saying that, no.
Nobody. So just to follow that through, besides you having no recollection of anyone else, as it were, delineating the criteria for the detection of a poisoning case, after that, was there any, it probably follows logically, was there any training for you or anybody else about the very factors you wanted to present?
Not that I'm aware of.
After you did present, which was the July date, after the death of Dawn, can you help us about whether there was any training then?
That audience was organised at DSTL, and admission to the audience was limited to DSTL staff and members of the military.
Right.
So what became of that, I don't know.
You don't know?
I'm not a member of either of those
No,
organisations.
very well. Now, this is a particular question arising out of the admission of the male patient in Salisbury, that's Sturgess Inquiry, all right?
Yes.
You've seen I don't ask for it to be brought up again. There's a record of that admission. And there are some words on it, not read out today, but they were read out yesterday, that the patient was very agitated. Now, I wanted to ask, because you indicated, as to whether this is what you were talking about today, that he displayed extremely odd behaviour that you hadn't seen before. Now, what was the behaviour that you hadn't seen before?
I'm just wondering whether or not this agitation was something that was written in the statement from one of the paramedics. Because from recall, I think the paramedics at the scene, they thought they'd given him naloxone,
right,
but they also, I think, gave him some haloperidol. Now, haloperidol is a major tranquilizer. So if he had been agitated at the scene, that haloperidol would have quietened him down. When I saw him, he was rigid and silent. He was like a statue.
So, when you said today, you talked about extremely odd behaviour that you hadn't seen before, you were talking about what you observed.
Yes, this rigidity and
the rigidity.
Yes.
Right.
Right.
So, does it follow that you hadn't seen it in the context of the other phrase you've used today, in the run of overdose patients that had occurred in Salisbury prior to the Skripal case? That's not a behaviour, or rather a sign, that you'd seen before?
I had seen it before, but not in recreational overdose patients.
Right. Well, I'll come to that, because I think you're going to say fentanyl, are you? Or carfentanil?
Or related drugs to fentanyl that are used therapeutically. Yes, I have seen it in those cases.
I think you told us that some potent opiates cause extreme muscle rigidity. That's my note. Is it right or wrong?
That is correct. Fentanyl in some individuals can cause extreme muscle rigidity, not everyone. And there's another agent that we use called remifentanil that's slightly more potent than fentanyl, again as an anaesthetic agent. And certainly it is quite common for those patients to develop such rigidity that it's actually quite difficult to ventilate their chests.
Now, when you did give your full presentation, did you include a passage in the presentation, if you can remember it now,
Yes.
that related to carfentanil?
Yes.
You did?
Because I also described this event I'd seen back in '93 at the same time.
Yes, all right, thank you. Now, one final matter, if you can help. There has been a concentration on the difficulty of distinguishing for either frontline medics, whether they're paramedics, or frontline in the hospital, between the various categories, whether they're opioid poisoning, organophosphate. Now we've got synthetics coming into this equation. Where you have the possibility that that what you're dealing with is poisoning, you can't be sure, but it's possible, particularly as an overlap. Now, is there, after Dawn's death, was there any attempt to, as it were, provide frontline medics, as far as you're aware, including hospital workers, as to how you might be able to distinguish, because you can't waste time. Time is of the essence, if you follow me. So is there some way in which you say to people, look, if you suspect poisoning, you've got to do X, Y, and Z?
I wasn't aware of that. As part of basic resuscitation and delivering medical aid in an emergency situation, it is drummed into people if there are mass casualties. If you've got one individual who's unconscious, that's unlikely to be a poisoning event. If you've got 2 or 3,
Yes.
then you need to consider it. And that is something that's been taught for years.
Yes, we've understood that.
Right.
I'm one step further ahead down the
Okay.
line, supposing you've got 3. But if you've only got 1, so you're not using that criteria, you're having to look at it clinically. What is the person on the spot supposed to be considering to do, either on the spot or back at the hospital, in order to ascertain that it's poisoning rather than opiate? Do you follow?
I do. If there has been any training since these events for the ambulance service, the police, for the emergency department staff, I'm not aware of it.
What about clinical staff in hospital?
I'm not aware of it. I left Salisbury Hospital 6 months after this incident, and I now work in the elective sector as a consultant anaesthetist.
All right.
So there may have been some training. I haven't heard about it.
Okay.
I don't. So I wonder if I can ask this final question. It's speculative, and you may feel it's not appropriate. So,
Try me.
I'll try. Yeah. The question is, although you're no longer at the hospital, so you don't know, are you aware, given your interest, pharmacological interest, are you aware of what would be or should be the protocol in the situation I've just described?
No, that's exactly what he can't say.
No, all right.
Phil, thank you very much for trying, but no.
If it helps, I'm still in
I
contact.
think you better not.
No, thank you very much, Dr. Cockcroft.
It's my fault.
Stick to one's expertise.
Blame me.
Right. Dr. Cockcroft, I think that's probably all.
Okay.
Thank you very much for coming to help. There's no need to stay
Okay.
local. You can listen elsewhere if you want to.
Thank you very much.
Thank you.
Thank you.
So
Yes.
the next witness is FT49. He is here, and as you know, we did have a plan that we would be able to move swiftly on to his evidence. I'm afraid that some technical matters have come to our attention. That means we will have to ask you to rise for at least 15 minutes or so prior to the start of his evidence. We're in your hands as to whether you want to do just that and start him before lunch or take an early lunch.
Well, that would really be quite an early lunch, wouldn't it? Let's
would.
start at 12 o'clock.
So yes.
Or as soon after that as you can. If you find that it's going for some genuinely unavoidable reason to be a lot longer, let me know and I'll send word.
We will do that, sir.
Thank you.
Ladies and gentlemen, would you please take your seats? We will be starting the proceedings again very shortly. Thank you.
Yes, Mr. O'Connor.
Sir, the next witness is someone who, for reasons I shall explain in a moment, we will refer to as FT49.
Right.
May I ask that he be affirmed, please?
Yes, please.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you, sir. Would you like to sit down, speak to the microphone, please? The questions will come from over there. Keep it nice and slow so that we can all follow.
Thank you, sir.
FT49, I'm not going to ask you to provide your name now. I make it clear that you have given your name to the inquiry, but earlier this year, following an application, the Chair made an order granting you anonymity, and so that is, you'll recall, in your ruling dated the 10th of July 2024, which is available on the inquiry website. Accordingly, FT49, the documents that we will be using that bear your name have been altered so that your name is replaced by the cipher FT49, and as will be apparent by now, that is how we're going to address you today. And I should also make clear that in order to achieve the anonymity that the Chair has ordered, your picture is not going to be shown on the video footage of this session of the evidence.
Thank you.
FT49, you have provided one witness statement to the inquiry, dated the 16th of September 2024. I'd be grateful if it could be brought up on screen, please. It is INQ 005997. It is 12 pages long. Perhaps we could just go and look at the last page, please. Thank you. FT49, is this a statement that you're familiar with?
Yes, it is.
And have you had a chance to review it in preparation for giving evidence today?
Yes, I have been able to review it.
And I think that there are 2 corrections that you'd like to make to it.
There are indeed.
Let me take you to them. First of all, if we could go to page 4 of your statement, please. And on that page, go to paragraph 14. And 4 lines down, you refer here to the circumstances in which Dawn Sturgess was poisoned, and you refer, by reference to the statement of Charlie Rowley, to, as you understood it, the fact that once Charlie Rowley had assembled the perfume bottle, Dawn Sturgess applied the perfume liberally to her wrists and neck. Is there a correction you'd like to make to that sentence?
Yes, there is. This was a cross-reference with a colleague DSCL statement, and it was not directly linked to a Charlie Rowley statement, as stated there. So I would like to remove the term liberally to wrists and hands, because that is an incorrect, that was an assertion from another statement.
Well, let's just take that, go to it, please. What it says in the statement is applying the perfume liberally to her wrists and neck.
Yes.
So what would you like it to say instead of that? Or do you simply wish to remove all of those words?
I wish it to say applying to her wrists.
Right. So in other words, remove the liberally and remove the and neck.
That's correct.
And so I think just...
Because otherwise it's not an accurate an accurate report of what you understood Rowley to have said. Is that it?
Correct, yes.
All right.
Thank you. And moving on, if we could go to page 10. Paragraph 37. This is FT49, a slightly less accessible part of your statement.
Yes.
But we can see that the second sentence in that paragraph currently reads, these therapeutic interventions aim to reduce incapacitation and mortality by raising ACH levels in tissues, thereby reducing the strong pro-cholinergic effects of nerve agents. Would you like to change the wording of that sentence?
Yes, I would. I'd like to remove the word raising and replace it with modifying. And I would like to, after the word levels, add acting at tissues rather than in tissues.
So could you just read it as you would wish it to be?
Yes. So
just go for mortality.
Mortality by modifying ACH levels acting at tissues.
Thank you. We will come back to these areas. I'm not going to ask you to give any further explanation of that language now. But with those 2 corrections or amendments that we've just made, FT49, are you happy that the contents of this statement are true to the best of your knowledge and belief?
Yes, they are.
Thank you. So I'd be grateful if we could adduce that statement into evidence in the normal way.
With those adjustments, yes.
Now, FT49, I want to start by asking you about your professional qualifications. And for those purposes, perhaps we could go back, please, to the first page of your statement. And we look at paragraph 4 of your statement. Is it right that you, in essence, have 2 strands of your professional qualifications? On the one hand, you are a qualified, registered medical doctor.
That's correct.
And beyond that, you also have a series of academic qualifications which make you a specialist in the fields of toxicology and pharmacology.
That is correct.
Thank you.
Have you actually been in clinical practice as well or not?
Yes, I undertake clinical practice.
And then if we can move down to paragraph 5, please. You state there that you currently work at DSTL Porton Down within the chemical, biological and radiological, the acronym CBR, division, and that you provide medical advice to the Ministry of Defence and other government departments on CBR-related threats.
That's correct.
And was that the role that you were undertaking in 2018?
Yes, I provided two roles. More broadly, medical support to the operations that were underway, and also direct medical support as a medical advisory role to the hospital.
Yes. Forgive me, it wasn't a very good question. So we'll come to exactly what you did in response to the events in Salisbury and Amesbury in a moment. But just as far as paragraph 5 is concerned, was that's how you describe the job you're doing now, and was it the same job that you were doing in 2018?
That's correct, yes.
So then if we come on, as you've said, and we'll need to go to paragraph 6 for these purposes, to exactly the detail of what you did as part of the response to the events in 2018. We look at paragraph 6, please. The first sentence, you say, I was chemical and biological medical advisor to DSTL and operational teams in support of the investigation into the attack on the Skripals, which, as we heard, was the police investigation Operation Wadana, and the investigation into the poisonings of Dawn Sturgess and Charlie Rowley, which had the police name Operation Reed. So I think you've already touched on this, but was this a role in which you were part of the support provided by DSTL to the police investigations?
That is correct. And other government departments when they sought for advice.
And just taking a step back from the events in 2018, this sort of support, in this case to these police investigations, is that a core part of DSTL's function?
In support of the UK Health Security Agency, and DSTL has a role as joined up cross-government agencies to support the police and other departments.
It's a source of specialist scientific support which can be called on by government agencies, including the police.
That's correct. Yeah, that's correct.
So that was that element of your role directed towards assisting and advising the police. And then, again, as I think you mentioned a moment ago, you had obviously a connected but separate role in supporting the clinicians at Salisbury District Hospital. And if we can read on in your paragraph, you say, I was a member and CBRN specialist advisor to the Salisbury District Hospital's Foundation Trust Clinical Advice Group. And you go on to say that in that capacity you were able to provide interpretation of non-clinical and clinical research knowledge to the clinical team for each casualty. Can you expand on that just a little bit?
Yes, so where there was either specialist knowledge or interpretation required from open literature so that we could support the casualties most appropriately to our best efforts, I was able to help with the interpretation of that data that may exist.
And one imagines that dual expertise that you have, that we mentioned a moment ago, in the sense that you are both a trained, registered clinician yourself, but also specialist in toxicology and so on. Did that make you particularly suitable to perform this role?
That's correct. I tend to term it translational medicine. So that is taking basic scientific knowledge and experience and being able to interpret in what may have best impact for clinical effectiveness.
We'll come back and say a little more about the role of the clinical advice group, but just to before we leave this paragraph, the remaining sections of this paragraph, you make it clear, is this right, that although, as we've heard, you are a trained doctor and you were providing clinical advice, that was still at one remove from the clinicians themselves who were taking the day-to-day decisions in how to treat their patients.
That is correct. There was an NHS governance process that we went through in the establishment of the clinical advisory group to ensure that there was separation between advice given and clinical actions. For the majority, for the Scripples, Dr. Haslam was the lead clinician and directly in contact with the patients.
Yes, so I was going to say, just so there's no mystery about it, when we're talking about the clinicians, we mean Dr. Haslam, Dr. Cockcroft, who we've heard from in the last couple of days, and also Dr. Jukes, who will be giving evidence next week.
Correct.
Amongst others, no doubt.
Amongst many, yes.
Yes, in fact, we can see just a little bit more about the clinical advice group. If we could go, please, to INQ 004691. Now, I'm going to ask to go to a page within this lengthy document in a moment, but before we do, this is the first page of a slide pack, is it not?
Yes, it is.
And in fact, were you listening to the evidence or watching the evidence of Dr. Haslam yesterday?
Yes, I was.
So you will have seen that Ms. Pottle asked him some questions about some of the slides within this pack.
Yes.
And this is the first page, the title page, Organophosphates on Our Doorstep, the nerve of it. And just beneath that, we can see the cipher FT49. So did the original bear your name as the author of this pack?
Yes, it did.
But we heard Dr. Haslam claim at least some of the slides for himself. Is it right that you drew on other people's work?
That is correct. This is a collection of the knowledge and experience at the time of pulling these slides together so that it could include all aspects, scientific and technical, through to clinical management. So although it bears my name, it has a significant number of other contributors to this slides.
As far as I can see, it's not dated. It may be the date doesn't matter too much, but can you remember roughly when this pack was put together?
Yes, primarily this pack was put together for the DSDL held meeting, which in previous sessions has been referred to as the third clinical learning episode.
So after the Amesbury incident?
Correct.
Thank you. So if we could go to page 40 within...
Can I just ask about dates, Mr. O'Connor, in case anybody's puzzled? The previous citing of this slide appeared to have a date on it.
That's something we can check.
Oh no, I see. I beg your pardon. It's not. It's the covering document, I imagine. Look at the bottom left.
Oh yes.
Excuse me, sir. I think that's a template issue from PowerPoint.
Yeah, I'm sure that's right. So we can ignore the 2012 date.
That's correct, sir.
Right.
I was ignoring that as too bizarre to make any sense of.
Precisely.
Yes. So if we could go to page 40, please. Those of us who have the full page will know that this page is dated 2013, so something very odd is going on. But the slide itself, we can see is headed the Clinical Advice Group, which is what we've just been discussing. There's a date there, the 6th of March 2018, which would be the Tuesday after the Scripple poisoning on the Sunday. What was that date?
That was, I think, the formal formation of the clinical advisory group.
Yes.
To my recollection, there may have been a limited number of people on that list that met earlier. I do recall being invited to the clinical advisory group 24 to 36 hours after its initial establishment.
Yes, but in any event, I mean, we see just underneath the title the words early establishment of expert clinical advisory group, and from what you say, at the latest, on the 6th of March and possibly a bit earlier, there was a group like this in existence.
Correct.
And just reading down, we see, some members of the group identified as internal. Would that be internal to the hospital?
That's correct.
One of which being Dr. Haslam, who we heard from. Then external, a number of individuals from other government agencies, Public Health England, Department for Health and so on. And then your name is at the bottom. Presumably you would be one of those group who were external to the hospital.
That's correct, yes.
And it would appear from the, we see just above your name, this became the daily clinical advice group teleconference. So we don't need to be precise, but was this a group which met daily or more often than that, less often than that during this period?
So as a minimum, we spoke daily for the entire hospital stay for both casualties in the first incidents. But we were available on an ad hoc basis to provide support should any questions come up from the internal clinical team. So early in the establishment of the clinical advisory group, we would meet and talk frequently.
And we see a reference to teleconference there. Was it always done by teleconference, or was it partly in person?
I can't remember pre-COVID whether it was Teams or another platform, but it was a conferencing setup. Yes.
And just out of interest, was it therefore was it fixed with those particular people, or did people come and go within those broad categories?
This was the core team.
Right. Let me move on, please, FT49, to a different topic, but we'll stay in this pack. I want to ask you fairly briefly, I hope, about the mechanism of Novichok poisoning. I say fairly briefly because we've already heard a little bit about it, and we will hear more next week from the expert witnesses, but it's important to get some evidence from you about it, in part because it will lead to other things I want to ask you about. So if we can go within this document, please, to page 12. And thank you. So, FT49, the starting point, perhaps, and in fact it's not the first bullet point, but we see it a couple of bullet points down, it is a chemical called acetylcholine, which is a chemical we all have in our bodies, which amongst other things I think is a neurotransmitter. Is that a fair summary?
That's correct.
And the next point to make, which is in the first bullet point you have there, is that we also then need to think of a different chemical, an enzyme, acetylcholine esterase, which has as its function, or perhaps one of its functions, breaking down acetylcholine. Is that also right?
That is correct.
And then we see, as you described in this slide, nerve agents, and we will come to the difference between Novichok and other nerve agents, but certainly this category of nerve agents whose function is based on, if you like, messing up the process that I've just described. What they do is inhibit the acetylcholine esterase and thereby prevent it from performing that function of breaking down acetylcholine. Is that right?
That's correct.
And so we then see in the third bullet point, when that nerve agent is doing that, performing that function of inhibiting the acetylcholine esterase, that then leads to a build-up of acetylcholine because it isn't being broken down.
Correct.
And it's that build-up which causes all of the symptoms that we've heard about from the various witnesses from the last few days. Is that right?
Yeah, that's true. You can term that a procholinergic toxidrome.
Yes.
But yes, that's true.
Well, and that's a phrase you use in your statement. We've heard the term toxidrome a few times in the last few days. Tell us what that means.
So a toxidrome is a constellation of clinical features. They can be symptoms or signs that you can use as a handrail to aid your clinical diagnosis.
Is there any significance in the syllable tox? Does it have to be a sort of toxic set of symptoms, or could it not be?
So in medical parlance, there's also the use of a prodrome. So that is a pre-event to a particular set of signs and symptoms, like a prodrome of a flu, for instance. And so toxidrome is just the toxy
It simply
collection
means a set of consequences.
No, not a set of consequences. It is a set of features.
All right,
Yes.
let's leave it there.
Yeah.
But then you said procholinergic, I think. Does that mean it's associated with this acetylcholine that we've
Yes.
been discussing?
So that a raised amount of acetylcholine gives you that procholinergic effect.
Okay, thank you. And we'll come to talk more about this, but in layman's terms, this build-up of acetylcholine, is this right? Essentially leads to bodily systems being overwhelmed.
Yes, that's correct. Dr. Haslam gave us a very good overview of the nervous system yesterday, and that constellation of signs and symptoms from this toxidrome have parasympathetic effects that look like those signs and symptoms that you see primarily.
Yeah. We've seen now really quite a few documents which attempt to list this toxidrome, this list of symptoms. They're not all identical. You've referred here to the meiosis, the pupil constriction, nausea, vomiting, sweating, secretions. We're familiar with all of those. There's one other that I wanted to ask you about, which we have seen in some of these other lists, which is the slow heart rate.
Yes.
And that's obviously of relevance to our case because of the fact that Dawn Sturgess suffered a cardiac arrest.
Yes.
I've certainly seen at least two descriptions in the documents about the mechanism by which this build-up of acetylcholine may affect the heart.
Yes.
I want to ask you about that. One suggestion is that there is actually acetylcholine within the heart, which in normal times performs a function of slowing it down.
Yes.
And when there's this build-up of acetylcholine, that has a sort of exacerbated effect and actually slows it down too much. Just let me put the other one and then I'll ask you.
Mm-hmm.
So that's something we've seen in the papers. There's also, I think this might be in your statement, a reference to a different effect of acetylcholine build-up, which is that it paralyses the diaphragm and stops people breathing, which causes respiratory failure, which causes cardiac arrest.
Yep.
Are both of those part of the truth?
Both of those are true, and but represent a stage in the clinical progression of organophosphate exposure. If I just take the first, the vagus nerve supplies the heart, and that has a cholinergic synapse. So basically an acetylcholine nerve supply. So that build-up of acetylcholine is what drives the heart rate down, generating that bradycardia. The build-up of acetylcholine within the neuromuscular junction, so the muscles that supply the diaphragm, the actual muscles themselves, rather than the nerves, that they become overwhelmed by that large amount of acetylcholine, and that stops those muscles contracting in your diaphragm. Goes into paralysis. So stops you breathing.
Yeah. And so it may well be that those two different mechanisms combine to produce the effect of the bradycardia and ultimately cardiac arrest.
Correct, yeah.
Thank you. Just sticking on this topic for a moment, I'd like to go back to your statement, please. So it's INQ 005997 and page 5, paragraph 16. Thank you. So in this paragraph, FT49, you describe the mechanism that we've just been discussing. You say that the Novichok nerve agents are highly potent, irreversible inhibitors of the enzyme acetylcholinesterase. You describe that's an enzyme that's involved in the routine breakdown of acetylcholine. And if we just read through perhaps ourselves, we can see you then describe the symptoms, which you've used that phrase at the end of the paragraph, cholinergic toxidrome, we've just been discussing. Yes. I wanted to ask you in particular about what you say in the first line there, about Novichok nerve agents being irreversible inhibitors of the enzyme acetylcholinesterase. Because it's right, isn't it, and this is something you explain in your statement, that that's one of the sort of characteristic features of Novichok as opposed to other nerve agents which act on the acetylcholinesterase.
So for organophosphate type compounds, there's a broad number of compounds within that group. Most organophosphates result in irreversible inhibition of the enzyme acetylcholinesterase. The speed at which they do that varies, but so it is a common mechanism for organophosphates. There are other drugs that can also inhibit acetylcholinesterase, but those are reversible inhibitors. For instance, some of the treatments for Alzheimer's disease are reversible cholinesterase inhibitors.
Right, so then I think you're quite right. We have to have in mind two related but different concepts. One is whether the agent produces an inhibition which is reversible or not.
Correct.
And you say that all of these organophosphate type nerve agents are in the irreversible category.
Correct.
But then within that category, that irreversible inhibition, different nerve agents arrive at that point with different speed.
Yes, correct.
And so I think, going back to the question I asked, it would have been more accurate for me to say that one of the particular characteristics of Novichok is that it produces that effect more quickly than others.
Oh, that's correct. It's highly potent, yeah.
Yes. Just give me a moment. So I'm told there's been a technical difficulty with the transcript. Apparently, there needs to be a reset, which will take a few minutes at least. Looking at the time, I
You want to shoo me away, do you?
I'm sorry?
You want to shoo me away for a bit?
Well, that's a rather sort of
that's all right.
crude way of putting it. But may I suggest that we take an early lunch now, perhaps until 1:30?
Yes, if that's what's necessary to make it all work, Mr. O'Connor, we'll do that. We're going to interrupt you until 1:30, FT49.
No problem, sir.
Please keep your own counsel in the meantime. You're in the middle of giving your evidence. Thank you.
All rise.
1:30.